Hi class. I am going to use a post-surgical patient care scenario to talk about the DIKW theory. So I'm just going to say that we have a post-cholecystectomy patient, and this is going to be 2 days, let's say 2 days post-op, and as a nurse I go into the room and perform a head-to-toe assessment. So in our assessment, we're going to be collecting our basic data, which are some of our objective facts and observations that we can make about the patient. So in my assessment, I go through and I find that my patient's temperature is elevated at 100.5 degrees. Their heart rate is slightly elevated at 110. And then I go down, I check their incision, and I find it to be a little bit red and swollen. And the patient states that they have 8 out of 10 incisional pain. Other than that, the rest of my assessment findings were benign. But these data points that were a little bit out of what was expected, I can take them together, and as a cluster they're going to convey meaning to me as a nurse, which makes them information rather than data. And from there I'm going to make associations and find a pattern here, and based on what I know about this pattern, I can interpret my knowledge and say that some of these data together, this information together, indicates a risk for infection. So beyond that, we do this every day. We use our wisdom beyond that to make clinical decisions. So wisdom is kind of the culmination of my knowledge and also my experience, so that I kind of have an idea of what I want to do in this situation, which is to call the provider, let them know about my assessment findings, and then we can kind of investigate this patient's situation further. We might want to order some labs, take a culture, or even start the patient on some antibiotics. So basically my understanding of the DIKW paradigm is that it's really essentially the theory and behind the framework and the thought process that nurses go through every day as they make clinical decisions.